Thank you very much, Graham. It's a pleasure to be here today. And actually, I'll just say two quick things before we start. One is it's actually all incredibly simple in terms of what needs to be done, and Graham covered pretty much everything in his first talk. And then it's incredibly difficult to put that into practice consistently across a large capital with diverse health needs and diverse, I think, opinion. And that's really what I'm going to talk to you a little bit about today. Really, it is about London TB Plan update and a bit of a journey, really, which I think covers, particularly for the trainees here, actually, a little bit more about talking about the NHS, actually, really, and how it's difficult for the NHS sometimes to take things forward necessarily than TB itself. But I'll start with one just quick bit about streptomycin, because I think I can beat the previous speaker. Because my mother and father met when my mother gave him his streptomycin injections in the early to mid-1950s. I think nowadays that could have related to sort of a referral to the Nursing and Midwifery Council, but anyway, I'm a helpful product of that. And just in terms of that, sort of where it was in those days, that was towards the end of his 18-month stay in hospital between the ages of 17 and 19. And that's just, I think, for the trainees in particular who don't remember, or, that sort of, or wouldn't know actually what that sort of type of TB was like. I think that's quite telling. Okay, so first of all, does anyone know that there was a London TB plan and there will be a new TB plan in the future? Just a few people, well, that's good. So we all know that TB is a significant problem. This is last year from the Chief Medical Officer report, who had a whole chapter on health inequalities and infectious diseases, which I think for the wider infectious diseases fraternity was very welcome, because it really forcing to say that there is a really important link between health, social care, inequality, and a range of infections. They use some funky graphics within that, and that's the sort of TB map of the UK at that time. So if we go back a bit, there was an organisation called London Health Programmes that was funded directly from NHS London and was charged by Simon Tanner, who was then the Director of Public Health for London, back in end of 2010, early 2011, to develop a London TB plan. And I came on board with that programme towards the end of 2012, at which point that plan was all made and sorted out and only needed to be put into action. And the reason I think people came in my direction is because I've got a slightly unusual career and hybrid sort of thing between management and clinical work. So I still do a fair amount of clinical work, but have held a variety of managerial type of posts. And I think it was recognised that the difficulty is actually putting good clinical plans actually into action on the ground, backed up by contracts, commissioning and all of that boring stuff. The aim of that plan, it was developed by a wide range of people throughout the TB clinical community, as I say, lots of public engagement, lots of engagement with clinicians and with different advocacy groups, and had an aim then to reduce the rate of TB in London by 50% over the next 10 years. How many of you think that that is achievable? Great. So as I'll come back to a little bit later on, when this all stalled and we took it to Duncan Selby, who's the Chief Executive of Public Health England now, he said that's not ambitious enough, you need to do it in 5 years. So that's where we are now, as I'll come back to from that point of view. And really, I mean, I just highlighted 3 main bullet points of what was in that plan. There was a big case for change, there was a big model of care, but really the 3 things were early detection and diagnosis of TB, including latent disease. That's really crucial in London, because as we all know, a lot of TB presenting in London is reactivation of latent disease acquired elsewhere. And therefore, although dealing with the people who are transmitting TB in London is absolutely vital to reduce TB, you won't get to a 50% reduction unless you begin to address latent disease. Improving the way TB services are commissioned is a real drive from the TB community in London that we really needed to sort out the social care and housing issue, and that's one of my great shames that really has not made as much progress as it should be, and addressing variability within TB services. And I'll just show you just a very small amount of data there as well. I still think we've got some of the problems, which actually link to quite a few of the things that Graham was saying. The case for change, very straightforward, and there's a lot of TB in London, variation in TB incidence and complexity across London, variability of service provision. So some areas really driving ahead, other areas, lagging well behind. We only did, if you remember, it was said that North West London's now got the highest rates of TB in London. I'll show you that in a second. And we only did our first cohort reviews out in North West London at the end of 2012, early 2013. And latent disease I've mentioned. Went through a number of things. I won't go through the whole of the case for change in the model of care, to be here for ages, but this just shows you how one of our objectives to improve the early presentation and early diagnosis of TB, reducing the opportunity for transmission of active TB, and also particularly, which I think often gets lost here, is early diagnosis gives you less complex TB, less morbidity for patients, less disability, less time off work. If you're a child, less time off school. So getting that diagnosis as early as possible. And what we had wanted to propose at that time was a programme to raise awareness amongst communities, amongst healthcare professionals. I still find it stunning where I'll go to a CCG meeting locally in Ealing and have people say, can you come out and give us some more information about how TB presents, which we're very, very happy to do. But you'd have thought sitting in the highest prevalence area, it would be a big priority to know that, and everybody would actually know that quite well. And a pan-London active and latent TB case finding protocol and a protocol for the treatment of latent TB. And we did some wonderful, slightly hypothetical cost-effectiveness stuff that said that if you put in 2012 about 20 million, by the time you got to 2017, you'd be spending less money on running the programme than you were on actually treating tuberculosis. So therefore, it would be cost-effective in about a 5-year period of time. So what actually happened then? Well, the main thing that happened then was a big change in how health services were organised in London. So that plan was taken to NHS London, which was then the main group running the whole of London. It was taken to the emerging CCGs, and it was taken through some of the public health forums, and everybody said, TB is important, we need to do something about it. But this is really what happened at that point in time, and this is the complexity of the health service in London at this point in time, the NHS landscape. And I'm not going to go through this in any detail at all, except to point out the very important role now that Public Health England is beginning to take. So our previous speaker talked about Public Health England and also her own role moving more into the local authority. And Public Health England has the role of setting the key public health priorities and linking through the NHS Commissioning Board and down through the clinical commissioning groups, but also with this really important link with the local authorities where the Directors of Public Health now reside, to actually really try to set what are local agendas to drive things forward. But all of this process, all of this structure coming into place did rather slow things up. So now I'm going to backtrack and show you some data around London TB plan. I also found it very helpful that just yesterday the 2013 data for London came into my inbox. So it's updated here. So as we heard before, it's 3,020 TB cases notified in 2013. Now this is a decrease actually. We're now down to 36.3 per 100,000 in London. That's the first time we've been below 40 in London for a considerable period of time. So it's a decrease on 2012. So you could argue, well, if it's going down and a lot of what needs to be done is local, why do you need a Plan London plan? I'll come back to that. We all know London's TB rate has gone up, and also that European cities generally have lower rates than London. And this is a graphic that comes from the European CDC, which is very interesting from that point of view. So if you look at London here, we're at 44 when this was done. This was 2011 data, 44 per 100,000 in London, with 14.8 for the UK as a whole. So you can see concentrated in London, and that is higher than pretty much any other city in Europe, in the westernised part of Europe, and higher certainly than North America and Australasia. If you go into the areas, I think, that were highlighted as the sort of drug-resistant disease beginning to move across, it is still actually more of a rural disease, but moving into the cities there, and then you're going to get the migration, as we've been seeing, across into the UK. So a very different pattern across Europe, but certainly highlighting London